Okay, we're going to go ahead and start this webinar. We are delighted to have Dr. Lois Wagner with us today, one of our esteemed faculty advisors. We're going to be hosting the third in our series of colloquia. And today's theme, of course, is the primary care clinic administration. We're delighted to have, I know we have some of our scholars online as well, and we encourage your participation. But before we actually get started, I want to just mention that I have unmuted everyone, but I would request that you mute your phones so that we do not hear your background noise. I know that Dr. Wagner is going to be offering, encouraging discussion at the end of this webinar, at which point I will again unmute you, and you can unmute yourselves and participate by audio. You can also send me chat questions down there at the bottom hand of your screen. You can send either Dr. Wagner or I questions by chat if you prefer to do it that way rather than use your audio. So with no further ado, I will turn this over to Dr. Wagner. And again, we are so grateful that she is with us today. And Dr. Wagner, can you hear me?
I can hear you.
Terrific.
Yes,
Thank you for being with us today. I will turn it over to you.
It's a pleasure, and welcome to everybody who's on the webinar. This, as she said, is the third webinar in this series. And in this webinar, we're going to concentrate on scholars who did their work in the area of needs assessment, evaluation, and client satisfaction. What I'm going to do in this seminar is first introduce the scholars, because after all, it is their work that's being presented here, not mine. I'm simply moderating this colloquia. I'm going to introduce them, and I will then present their projects, and we do have 10 projects in here, so unfortunately, I've had to condense a lot of information into some very brief talking points. Fortunately, it looks like we do have some of the scholars on here, and they will be able to jump in and defend their work. I'm going to then give some reflections on this, and then I'll open it up for discussion. I want to introduce the scholars, and I know that some of them are here today, as is Adrienne Bast. She did her project at Matthew Walker Comprehensive Health Center in Nashville, Tennessee. Etalyn Brown, who worked with the United Health Services in Nashville, Tennessee as well. Nick Cudjoe, who I believe is also on the line, who worked with Watts Healthcare Corporation in LA. Alicia Ellis, again, I believe Aisha is online. She was at Adelante Healthcare in Phoenix, Arizona. Hal Flowers, again, Hal is online with us. He was at Central Mississippi Health Services in Jackson, Mississippi, as was Christy Goodman, is also online with us. Rebecca Ives is worked with Adelante Healthcare as well. Denny Jackson, who I'm hoping will be joining us today, was also at the Central Mississippi Health Services Center in Jackson, Mississippi. Michelle Strong, who was at St. John's Well Child Family Center in LA, and Emily Wang, who was also in LA at the Northeast Community Clinic there. I want to start with talking about the presenting to you the needs assessment projects, and I grouped 3 of them within here, and I want to say this is an interesting bunch of topics, and I want to present each in turn briefly, and then we'll go on to the next topic. The first project that will be presented here is that of Adrienne Bach. And again, she was at Matthew Walker in Nashville, Tennessee. She is a medical student, I believe. And she was at Matthew Walker Community Health Center, which is I believe it is the first qualified health center in Tennessee, and it's here in Nashville, Tennessee, which is where I am right now. She gave some background on the population there, which was predominantly female, which turns out to be true at many of the community health centers. 43% of them were Black or African American. You can see about a third of them were Caucasian, and about 20% Latino or Latina. And you'll see in many of these community health centers, Many of the people who attend there, in this case almost 70%, were below the poverty line. They had a concern about patient access at the Matthew Walker Health Clinic, and she determined that this is such a short time frame for these products that she felt it might be useful to look at some of these issues surrounding the program and the population, how she might go about establishing some community relationships with there, and then have this information available to future scholars who attend these programs, maybe to give them a leg up on what they're doing. And I think many of the scholars identified this as a very compressed time frame in which they need to get their projects going, and I know they hope to leave a legacy when they leave. The method that she used is she distributed Spanish and English patient surveys, and her focus was on barriers to access, transportation, internet and social media, program needs, and their willingness to participate in programs. She was able to distribute and get a return of 50 surveys on this, and she found that about 38% drove to clinic, meaning that there was a pretty high percentage of people who couldn't drive to clinic, and they were dependent on bus and taxi or maybe walking. And although 72% lived within 30 minutes of the area, this still presented a burden for many patients trying to attend these clinics. As a result, about 37% said they were not willing to attend programs at the site, and they preferred the brochure method, or that kind of thing, or access to the Matthew Walker website. However, only about 28% of the people in her sample were able, even had internet access in their home, and about 40% were using Facebook. So what she decided to do, with the advice of some of the people at her site, was to create some information packets that might be used about programs and distribute them during their clinic visits, and also make data available on the Matthew Walker website. And I think this is important information because it is such a compressed time, and our scholars do need to have a leg up on what is going on there. I'll let her address some of these issues later as we get to this. Alicia Ellis was the Adelante Healthcare Center in Phoenix, and this was a little bit of different patient population. Aisha was interested in integrating sexual health and STI prevention information in the primary care setting. She found that, and she was particularly interested in HIV testing and services. She found that Phoenix was disproportionately affected by HIV. They had a high number of infections, but also a high number of unknown infections. And she was interested in looking at the barriers existing between patients and provider, which may inhibit HIV screening. A large patient population, over 40,000 patients, and they serve a lot of migrant workers. 52% are Hispanic and Latino, and you can see that about 30% are Caucasian. A much lower level of Black and African American clients are seen at this place. And again, 75% below the poverty level. She was in the evaluation of HIV testing trends in this organization, and she wanted to identify methods to increase HIV testing. She did some secondary analysis of their electronic medical record from several of their clinic sites to determine if HIV services patients were receiving HIV services they needed. And she used ICD-9 coding, looked at viral disease, HIV status, and HIV counseling to gather her sample. In findings, she found that about 3% of the HIV sample that she looked at had been tested, and she had found that 50% in the OBGYN clinic had been tested. That, of course, patients in OBGYN clinics it is recommended by the CDC that they all be tested for HIV. So she determined that the testing rate was relatively low, and made some suggestions to the organizations, which they were happy to receive. And she suggested that perhaps providers should increase the number of HIV testing screenings for HIV that they could do at clinic to enhance case finding. She recommended that they obtain a sexual health history at each annual exam, and actually suggested that they add a sexual health history screen in their EMR. Also recommended providing training on HIV prevention to the staff, how to obtain a health history, particularly sexual health history, and she found some issues with respect to proper coding of HIV so these data can be tracked. And she began to develop policy regarding HIV testing, or that the organization should, for the purposes of and also develop a secondary prevent plan. I'm going to move on to the next one, which is Hal Flowers, again, who did an assessment of community need. He was at the Jackson Hines Comprehensive Health Center, a large FQHC in Jackson, Mississippi. I believe this is one of the first comprehensive health care centers that was established in the United States, along with another up in, I believe, Massachusetts. And he went in and talked with the CEO of that organization, who indicated that this clinic was wanting to expand into other areas of the state. And one area they were moving to was Edwards, Mississippi. So in advance of that, they asked him to go to that community and determine the health needs of the residents of Edwards, Mississippi, in advance of them opening their clinic there. What he found was a relatively typical community health set, but the community, what down in the Jackson Hines Comprehensive Health Center was a relatively typical population for those health centers. What he found in Edwards was that this population in this town was about 83% Black and African American, so very large Black and African American population. And it was, and relative to Mississippi, had some different demographics. So in this area of the state, there was a far larger Black and African American population, a larger number of female head of household, and a lower education levels in this community. He wanted again to determine the healthcare needs of the residents. He distributed a paper survey in senior centers, the fish market, to the basketball team, and then a snowball effect with them, taking them to their families and their neighbors. And he was really focusing on healthcare utilization, history, needs, and access to care. He received 112 surveys, and I'm sorry for this typo here, but I think it was about 59% of the patients in that area had seen an MD in the last 6 months, 78% for primary health care needs, and he identified a gap in service in the need for dental and eye care. He found that 83% were able to seek health care when needed or sought health care when needed. Many of them had to travel quite a distance to get there. I think approximately, and he'll have to correct me if I'm wrong here, that about 30% of the population, maybe 29%, are already using the Jackson Hines Comprehensive Health Care Center. Many came from a broader geographic area around there. So he found that one of the barriers to access was transportation and the cost involved with that, and many of them did not have third-party insurance. I'm going to move along now to the reports to program evaluation and program development, and we have 4 people who worked and did their work in this area. One of whom was Italo Brown, who I believe is a medical student at Meharry Medical College, and he was interested in doing an evaluation and needs assessment with the university health systems. Excuse me, I'm going to move on to the next slide. With the neighborhood health systems here in Nashville, Tennessee, and he was particularly interested in looking at their diabetes and hypertension programs. He found that the people attending this clinic were disproportionately affected by diabetes and hypertension, and were underserved in this area, and that, of course, the federally qualified health centers offer support services to underserved patients in dealing with this area. And he found that they had a pretty well-structured programming, and the purpose of his project was to evaluate this diabetes program, look at a need needs assessment for their healthcare unit and develop recommendations to enhance the program without increasing cost. He engaged in dialogue with personnel in these programs. He observed the program components and completed a needs assessment. His goal was to complete a needs assessment of the resources and the community. He found that there was some inconsistent participation in the diabetes and hypertension programming, that patients who do participate enjoy doing classes at the facility, and that there were nutritional components that were really not being provided in his assessment to these students. Cooking classes had a poor response. Patients struggled to identify healthy foods and those types of things. And they struggled to afford the suggested diets. I concluded that the issues, the social determinants of poor nutrition were vital to be dealt with in this clinic. Enhancing access to foods, particularly healthy, fresh fruits and vegetables in these areas, and increasing the utilization of food stamps. His intervention was to develop materials that outline positive behaviors, purchasing behaviors for the clients using health stamps, and to allocate materials to high traffic and demand areas identified in his needs assessment. Goodman looked at pain management in an ambulatory setting. He was interested in a chronic pain policy to guide chronic pain management in the primary care setting and to improve the quality of life and minimize the use of narcotics. Her assessment of the community health center where she was located found that that 14% of those patients who had care, and their risk factors were included. They were female, minority, low SES. There was a lot of obesity, but many of them were managed in a primary health care setting. She went at the Central Mississippi Health Services organization that a couple of other scholars were located. And she found that it was a relatively older population. 56% were greater than or equal to the age of 65. A high number of Black and African American patients, 96%, and again, a large number, about 3/4 below the poverty level. Her method was to determine what were the current best practices regarding chronic pain management, and what were the best practice guidelines to manage this type of care. And historically, chronic pain management has either been neglected or under-recognized or under-managed in primary care settings. So she was interested in developing a chronic pain policy and guidelines for the providers in this community health service center and at this organization in Central Mississippi, and to meet with the chronic pain committee at this center before and after policy development, which she did. What she found was that the referral mechanisms in place for providers was really not adequate to manage chronic pain in this particular population. And patients complete screening questionnaire. What she had patients do was complete a screening questionnaire followed by a review of the chronic pain committee within 2 weeks. In conjunction with the chronic pain committee and the data that she gathered, a chronic pain management contract between the chronic pain management committee and the patient was developed and will be administered to patients. And this is also developed in line with adherence and non-adherence policy and guidelines, and concluded that proper management of chronic pain in primary care settings can reduce the cost and the pain burden and the quality of and improve the quality of life of patients who come through primary care centers with a chief complaint or a complaint of chronic pain conditions. And this seemed to me and to her kind of a wake-up call, I think, for this clinic, and I think she has left some good information behind for this clinic to move forward. Another scholar in this area, Rebecca Ives, was at the Adelante Clinic in Phoenix, again, a predominantly Hispanic population. And motivation for doing her work was that she had observed inappropriate and what she felt were insufficient communication between English-speaking providers and Spanish-speaking patients in her previous work prior to coming to this clinic. And she was really interested in looking at this in this population. This clinic is located in Maricopa County in Arizona, and I think that she said that about 52% of the population were Hispanic or Latino. I think we addressed that before. And she found that they did have kind of inconsistent access to Spanish interpreters. Although many of their medical aides did speak some Spanish in the area, she learned that perhaps this was not quite sufficient to meet the needs of the population. And so, as I said, she was looking at evaluating the efficacy of communication between Spanish-speaking patients and their English-speaking providers. She interviewed Spanish-speaking patients at the clinic. Questions related to the language their provider spoke, the use of and or their preference for an interpreter to be there with them, perceived understanding of what they had heard from their provider in their visit, and whether she felt that there was discordance in the information they received based on language barriers. She interviewed 18 people. She found that despite some of the language barriers, there was overall satisfaction, and they felt that they did basically understand what was said in the clinic visit. She found, however, though, that Spanish-speaking patients did have increased satisfaction with their clinic experience if they had a Spanish-speaking provider. And although they were satisfied with their level of understanding, she found that it really was not perfect. She recommended, and perhaps they will do so, that they add these questions to the current patient satisfaction survey that they do in the clinic, and that it is important to continue to evaluate the level of understanding between Spanish-speaking patients and Spanish-speaking staff, interpreters, and providers. She felt that the current practice was adequate, but she had hoped that this survey and this intervention would heighten awareness about this issue and increase commitment on the part of this staff to provide services that are language friendly between the providers and the patients. The next report is that of Emily Wang, who was interested in the mental health integration in the primary care setting in the clinic she was at, Northeast Community Clinic in LA. She has a professional interest in mental health and came to this project wanting to look at in a primary care center. This clinic is an FQHC in LA County, and about 3% of the patients do have a serious mental illness in this county, and she found that about 34% of these patients with serious mental illness had unmet needs through their primary care, whatever care they receive. Perhaps many of them do not receive any care. And Medi-Cal requires that primary care referral be requested in order to access mental health care services. So anticipating that primary health care centers have indeed an obligation to assess for mental health concerns and to make appropriate referrals, perhaps even treat in those settings. The Northeast Community Clinic was implementing a new mental health integration system, an attempt to meet the demand and enhance access to care. She was interested and took on the project of assisting the administrative team with program implementation of this mental health integration program, so it meshed nicely with her professional interests as well. She developed forms, documents, looked at workflow and policies and procedures that were going on in the clinic, learned a lot in this process in terms of, defining workflow and relating that to policies and procedures, and left knowing that the program implementation was underway. And she learned a lot from this experience. First, she learned a lot about governmental health care programs and administration processes, procedures in these types of clinics, healthcare settings, and she came away with an increased understanding of program development processes. So it sounds like a very good experience for Emily, and that she left behind a legacy from which this organization can move forward. In the area of client satisfaction, I looked at 3 reports, and I can see now that Tiffany Jackson, one of our scholars, has joined us now, and I'm happy about that because we would all the scholars to participate in the discussion after this. She was at Central Mississippi Health Services as well, and she was working with an organization, or working under her title actually is Patients First at the Central Mississippi Health Services Center. We also have in here Barbara Michelle Strong and Nana Cudjoe, who also presented reports in the area of client satisfaction, and I'll get to each one in turn. Starting out with Nana Cudjoe. Nana was at Watts Healthcare Corporation, and she was conducting a satisfaction survey. Is that she had a professional interest in private care, underserved and disenfranchised populations, and had experience in public health, so was interested in integrating this into her experience as well. This healthcare center is a very large healthcare center, about 52% Black or African American, about 42% Hispanic, again, predominantly female patients and predominantly people who were below the poverty level. And this organization required patient satisfaction for this project. Many of them do require patient satisfaction surveys, and so she was engaged to help with that. The purpose of this was to increase understanding of the CHIC system and the clinical experiences there, and to assess patient satisfaction administering the HRSA patient satisfaction questionnaire. She did administer this questionnaire and had a remarkable return of 100 surveys. Unfortunately, due to the limitations on her time at this center, she was only able to analyze about 20% of the data, but the clinic has expressed interest in completing this analysis, and I think that she can rightfully feel that she's left a mark on that organization that will help them as they go forward. Found in her sample that 70% were women. You can see the statistics here for African American and Hispanic populations. 70% identified that their experience at being seen at these clinics was very good. 45%, though, believed that they had only a fair to poor return on calls, and 65% felt that the waiting time was too extensive. Overall, they perceived their providers in a very positive light. 96% felt that their interactions with them were good to great, and they were very satisfied with the cost of health care. So overall satisfaction, she found, was very high, but there was a need for improvements, particularly related to wait time and return of phone calls. And her future plans as a result of this are that she would like to go into primary care as well and eventually run a CHIC. Jackson, again, I already gave the title for her, Patients First at Central Mississippi Health Services, so she again was in Jackson, Tennessee. And Tiffany did a very good job, very interesting. I hope many of you get a chance to read this. An extensive history of Mississippi, going back to Native American residents in that area, and of the city of Jackson, that really was illustrative of the current discrepancies in socioeconomic factors and healthcare access, and was able to kind of tie that in with the history of the country with respect to the civil rights movement, and was a very interesting background on this project. Jackson, Mississippi is a large city in Mississippi. The largest city, as a matter of fact, the capital of the state. Approximately 80% Black or African American, with a median income that's lower than the rest of the state. A higher education level of education. So interesting finding there. Again, 27% were below the poverty line, although 21% of the entire state of Mississippi is below the poverty line. And a predominantly female population, a high number of Black or African American patients at the clinic, about a 33% or so below the poverty level, 4% uninsured. And this organization was seeking I don't know what I forget what CHM status stands for now. I think it's a recognition they need to become a certified primary health care center, and I'll have Tiffany fill in the blanks on that when we get there. The purpose of this was to assess patient-physician relationships, ascertain what the patients were coming in for, the reason for their business, and Central Mississippi Health Services compliance with NCQ standards. And, I'm not sure what CHM for, but they were seeking certification in this area, and they were particularly interested in looking at medications, including narcotic use, coordination of pregnancy care with obstetrics, preventive care, including pap smears, mammograms, smoking cessation, immunizations, etc. The questionnaire was administered to patients while in their room before the visit, and it was reviewed by the provider prior to going into the visit, and then this in turn was documented in the electronic medical record. Found that the questionnaire was received. In the process of filling out the questionnaire, the patients perceived a decreased wait time, which was a positive effect. They perceived that they, in fact, were more involved in their own health care as a result of filling in this survey. And, the providers and the patients suggested that it improved patient recall of questions and concerns prior to the visit. The providers felt that it enhanced the information they received, and the providers were fine with the survey or the questionnaire. Again, the findings were documented in the EMR, and these data will serve this organization as they seek status or recognition as a patient-centered medical home. So this is part of what they were seeking in this. It's apparently a very lengthy process to receive this status of patient-centered medical home, and this was part of fulfilling that process. Very helpful to the organization. Brong was also looking at using satisfaction surveys in a patient-centered medical home setting as well. This is St. John's Well Child and Family Center, and they too were seeking this certification as a patient-centered medical home. And she had 116 surveys that were collected from both the pediatric and adult clinics over a 2-day period. And the purpose was to assess the strengths and weaknesses of this organization's compliance with the standards that need to be met in order to get this patient-centered medical home certification. The method that was used was to look at patient satisfaction surveys that included 4 of the 6 must-pass criteria that are needed to get this type of designation. These are criteria established by the National Committee on Quality Assurance. And they looked at access during office hours, care management, support, self-care processes. They tracked referrals and follow-up, and the surveys were, of course, administered in both English and Spanish at the time of registration. She called 116 questionnaires. It was a Likert-type scale, bordered always and never, and looked at items that received a less than a 50% always score, and those items were targeted for improvement. Sample demographics were that about 82% of the participants were women. The median age was about 45. A high number of Hispanic and Latino, 71% in this clinic, and 22% Black or African American. Areas that were greater than 50% where they did well was in health education, support referrals, and medication follow-up. Discovered that areas for improvement included ease of getting an appointment, the ability to choose a provider, and an explanation of payments. Overall, found a high satisfaction level, and then given the at-risk communities in this organization, it was pleasing to see that there was such a high satisfaction with health education and support referrals. She highlighted in their strengths. Her recommendations for improvement included increased staffing to handle appointment scheduling, better handouts and explanations of services, their choices, how payments are processed, etc. And she really felt that it was very important to hire a Black or African American patient representative. She felt that this would enhance patient satisfaction for the African American clients in this center. I know this is a very brief overview of the incredible work that these scholars did, and as I was reading through them, I had some reflections of my own that I wanted to share, and then hopefully this will lead into some discussion. Of course, we had 10 scholars, 10 different projects, things centered around satisfaction, evaluation, community program needs, primary care and patient issues, program operations and administration. I could not identify the professional background of all the scholars, but we did have PAs, nurse practitioners, and MD students. But all did an incredible and worthy job and left valuable legacies behind when they left. They were in a diversity of settings geographically. They were in the Southeast, in Nashville and Mississippi, in the West, in LA and Phoenix. The scholars were universally complimentary of the people they worked with at these clinics and indeed the whole experience they had over the summer, and all, of course, were appreciative of their mentors and the program for this incredible opportunity. Some of the scholars came in with ideas that when they got into the real world of the community health centers had to be modified for a number of reasons with respect to meeting the needs of the clinic and also focusing and narrowing their project to be able to do the project within such a short time frame. I think many of them increased their awareness of the populations that are served, barriers to access. They really honed in on the necessity of focusing and planning to get their project up and running within this time period and get some deliverables out over this short period of time. think there were a lot of lessons learned here for future scholars, and I think there are also some future opportunities where future scholars could come in and maybe pick up on some of the things that were done and maybe take off from there. And I think many found a future career direction, or at least looked again at some of their career direction options as a result of this. The outcomes included the opportunity to begin projects that may be hard to get up and running in a day-to-day operation, but because they were in there focusing on getting something done in these clinics, I think they were truly of benefit to many of these clinical settings. And I would like to comment on just some of the stuff that the scholars did. Mr. Flowers, his assessment of the needs in Edwards, Mississippi was invaluable for helping them inform their program expansion goals. Mr. Brown looked very seriously at program evaluation in diabetes and hypertension. Ms. raised issues regarding Spanish-speaking patients and their English providers that I think will serve this clinic very well in the future. Ms. Cudjoe and Jackson and Strong assisted these organizations in data collection regarding patient satisfaction, and also helped to move them along in their process of seeking patient-centered medical home status according to the National Committee for Quality Assurance Standards. They highlight clinic operations, both in their strengths and areas for improvement. I think, again, this is an opportunity for perhaps future scholars to build on these programs and move forward. And I think it's also a good opportunity for the community health center movement to maybe begin to grow some of their own as they work in these projects and perhaps go on to seek career in this area. Important issues that came to the forefront was Ms. Ellis's findings regarding HIV testing, very important topic and important data, and perhaps there will inform this clinic about how to increase their rates of HIV testing and case finding. Ms. Man's work regarding chronic pain management, a huge problem in primary care clinics, and one that oftentimes primary care providers are not necessarily that comfortable. So this was an excellent project. Again, I think it will serve the community well. And Ms. Wang addressing the mental health care issues in primary settings, again, an underserved population and probably an underappreciated part of primary care. I personally learned a great deal about the program. It's been my pleasure to serve as an academic advisor. I enjoyed reading about these various sites and the scholars' experiences there. And I want to say again how much I enjoyed Ms. Jackson's history on Mississippi from the period of American residents in this area through slavery and the civil rights movement. Now, it connected to the current conditions and healthcare disparities we see in Mississippi and indeed throughout the Southeast and across the country. So I want to commend the scholars on their work and thank them for this work and for the opportunity to review their work and present it here. A couple of recommendations I had was I think Ms. Bask's point was well taken. It's nice for future scholars to be able to see the work of scholars, learn about those organizations, and they do have a lot to do in a short period of time, and this may be very helpful. It may be helpful, and maybe the organization already has a library of reports by previous scholars, but I think that would be a very important thing to present and make available to future scholars. I have really nothing more to add there, and I think at this point I'll open it up for discussion and reflections from the participants.
Terrific. Thank you so much, Dr. Wagner. This is Melinda chiming in again. I just want to let everybody know here that I am going to unmute all of you en masse. So if you do not want to participate by audio, please mute your own phone. But I'm going to unmute you all right now on the WebEx system so that you all have access to participate. But again, please mute yourselves if you do not want to participate, so to minimize background noise. But again, I also want to echo what Dr. Wagner just said, that we've been just so pleased with the level of projects that we have seen here from the scholars, and we're delighted with this series of colloquia. We appreciate you all attending. By the way, I'm going to add one more thing, that there are a few people who are on the call today that are not registered, or their name is not showing up. So please send me a little chat there in the bottom right window of your screen. If you'll expand that, send me just a little message and let me know that you're here, just so that I can make sure you get credit for attending. And of course, I'm referring to the scholars. In any case, it's open for discussion. Thank you.
Hi, this is Aisha. Hey, I just wanted to comment on my project. In general, when I'm working in primary care, my background is women's health, and every patient we ask would they like to do an STI test or an HIV test. In primary care, I noticed that providers are not asking that question at every visit, and I'm not sure how often they are asking it. And I came across this electronic medical record data. It was interesting to see that only 3% of the patients in the entire population were being tested for HIV. And looking at the one in some 50% of the patients were being tested because they were in OBGYN. And I feel like as providers, we do patients a disservice by not promoting secondary prevention of HIV by promoting HIV testing. I felt like this huge revelation that I had, and looking through all the research about HIV prevention, there were tons of stuff about primary prevention, tons of stuff about behavior change, and getting people to have safer sex as opposed to making people aware of their status. The things I did find that were focused on people that were already HIV positive, knew that people's behaviors did change once they noticed they were HIV positive, change the better. Change to have safer sex interactions because they knew they were HIV positive. So I feel like we know for a fact that 25% of the people HIV positive do not know their status, and so if we get those people aware, maybe we can lower the spread of HIV.
Thank you so much for your comments. I would concur with you 100%. Actually, HIV is my area, has been my area of expertise going back to the early 80s, and it's hard to believe. This day and age, we're still having issues with comfort with sexual history and primary and secondary prevention in primary care. I did appreciate very much your background on AD nationally as well as in Phoenix. So I'm going to let it go there. I heard somebody else chime in.
Yeah, this is Tiffany Jackson. I was just going to ask, because I'm in a year now and I'm learning that, pediatrics versus medicine versus internal medicine have various standards for how they recommend prevention. So I was just wondering, did you know of the actual, recommendations from like the United States Preventive Task Force or anything in particular for HIV testing?
Recommendations that I saw was in ACOG that said that women should be tested twice during their pregnancy for HIV.
That was it? Wow.
That's it. I didn't see anything that was a standardized testing method. I don't know if Dr. Warner knows.
This is Kristen. I believe that the CDC current recommendation is that everyone be tested for HIV at least once, and then more frequently for certain populations.
Yeah, it's something about at-risk patients being tested. In reality, everyone who has sex is unprotected at risk.
Right.
I think the recommendations are every individual, maybe over 18 years of age, is tested at least once in their lifetime.
Okay.
Cunningham, can I jump in here? Can I being heard?
Yes.
Okay. I've been part of an advisory group, and I've been involved with HIV primary care for decades. Just for the benefit of the scholars on the call, the CDC recommendation is for everyone who's sexually active to be tested, not once in their lifetime and not at risk, but everyone, so that this becomes a routine maintenance program for every single person who's sexually active in the country. The issue is that some of you have identified is this doesn't simply happen quickly. This recommendation, I believe, is only a year or 2 years old. The primary health care that funds the health centers has identified this, and materials have been made available, and it's a slow process. Some states actually have restrictive with respect to consent. New York has probably been one of the worst that's slowly working it through, but it's not quite as easy as simply saying, yes, we're going to do it. But the important thing is that it has been identified. It is a high priority for HRSA and primary health care to begin this happening, and I'm delighted that this was put out. It's obviously a big issue. It's a big problem. It's challenging, and it's not as easy to do as one might think, just pushing a button. But it's beginning to happen everywhere.
Thank you for that input. And Aisha, I'd like to also state that she identified another issue that we're seeing in HIV, the prevalence of HIV in people over 50. Not only people who are living with HIV over the age of 50, but also people who are becoming infected over the age of 50. Another area that is little known, I think. Thank you.
And running him again as a senior retired chief medical officer who's actually 68 now, I'm delighted that the world is recognizing that we people over age 50 are still sexually active.
Thank you.
And continue to be, hopefully.
For years
Big
to come.
deal.
Any on the other projects?
I'd like Merle Cunningham again. For the people that worked on patient satisfaction, centers you were at, those that are on the call, did you find that the center already had a fairly active patient satisfaction survey process in place, or did you find that it was rudimentary and you helped to move it along?
Hello, this is Tiffany Jackson speaking. The Central Mississippi Health Services did not seem to have a patient satisfaction process at the time, and it was kind of interesting because I was able to work on the visit tool at the same with the lady who was in charge of the MP that was in charge of quality improvement and assurance, and by kind of creating a survey where the patient could their information, and also it could also survey whether or not they were satisfied, as well as getting information for the provider, kind of bolstered the use of it there. And so I think they're going to continue to use it and kind of change it depending on, the changes in care, or, so I think creative they could use as well, kind of then put that survey into action, because they didn't have anything at the time. So.
Nana Cujo, and I was at the Watts Health Clinic. Am I being heard?
Yes.
Yeah.
Sorry. So with Watts, they actually had a system in place, but had kind of fallen through the cracks in the past couple of years. So I would say from about 2008 to about 2010, they're consistently administering the surveys, but due to the facts and lack of funds, unfortunately, they were able to do that. So I was really attempting to make sure that it was something that would be continuously done, because times change, things change, and that's something that I found to be important. So Their biggest issue was having someone who can actually administer it and then actually analyze the data. So it was almost a financial issue as well, is because that would require hiring someone, which meant, excuse me, more would have to be allocated to an individual. So it was one of the problems that I ran into when I was there.
Yeah, I mean, I think the real, there's some that were representative.
Hello? Fading out on someone's mic there. I don't know if that was Dr. Wagner, but
no problem. Oh, I'm Adrian. I was at Matthew Walker, and they have students from Meharry who do rotations there, and they actually have those students work on their patient satisfactory surveys, and so they're very well established system.
Well, very interesting that people were seeing primary health care or primary medical home status, and this is an essential part of doing that, and it's like an area where it may be difficult for them to find the time and resources to do this.
Well, and unfortunately, I've been involved with this area for several decades. Doing routine patient satisfaction survey has been an expectation of these programs for at least 30 years. This is not new, and it really is related to patient-centered medical home, which is a notion that's only been around for a relatively short time. So it's a little disappointing to hear that some of the larger centers that you were at don't have a fairly well-developed process in place that they've had in place for many years. It's always, as I've said, been an expectation of the Bureau to do routine satisfaction surveys. So it's a little troubling, again, to hear that so many places aren't in very good shape on that.
I'm gonna add that when I was doing this is Tiffany. When I was doing some research on the patient-centered medical home, what I got from it was that the idea was having doctors and physician assistants and NPs working there, that ultimately they would like to decrease the patient load down from 15 patients a day to some number, and then I was thinking that may alleviate having to hire someone else to do the financial problems of having to hire someone if the actual patient load is less, and they may have enough time possibly to document that information. So I thought that was the idea of a patient-centered medical home, was to get down the patient, have time with the patient as well as have less patient load during the day.
Well, again, that's really not the major driver behind it. The major driver, of course, is the focus is principally on the patient. The reality is, in the country, with more and more people being covered by insurance under the Affordable Care Act, there isn't enough primary care capacity to go around. So the notion of centers actually cutting back on the number of patients they see isn't really going to happen, because they're overwhelmed with people coming in, and there'll be more people with insurance as opposed to people uninsured. So the issue of the team approach is really making sure that the people provide services as part of a team at the level that they're licensed to function at the highest level, with more things being done by non-medical personnel where it makes sense, such as home visits to check on how well people are doing with their medications and their asthma triggers and so forth. So this is a big challenge in the country, and for those of you that are going through school now, you'll continue to hear more and more about this. There isn't enough capacity to go around for the number of people that need to be served. So part of patient-centered medical home challenge is to figure out better ways of getting the job done so that people feel like they're satisfied and being listened to, which means involving more members of the team in lots of different ways.
And Dr. Cunningham, what is the view on the impact of the health care law with people getting more third-party coverage, the impact on the community health center system? Well,
the reality is that nationally the health centers average around 45% of uninsured, and the rest are people with insurance, including Medicaid. The expectation is that some portion of the people that currently come in that have no insurance will have some insurance. Obviously, there's a fairly substantial part of the uninsured population that will not be eligible because of their citizenship status or lack of their citizenship status, which is a requirement in the Affordable Care Act for the expanded coverage. So the expectation is that there'll be more people with insurance, some of which are already seeing, but there will be more people total coming in, or at least coming for service, because with mortgage there are still fewer from the private sector that want to take Medicaid. Medicaid still is not universally accepted throughout the country in the private sector. So people with Medicaid now have limited choices, and the health center is one of the few places that they may go in many parts of the country. This is certainly the experience in Massachusetts in the last few years, with the volume picking up, more paying customers coming in, but the total volume picking up, and the centers in Massachusetts have done the best they can to expand their capacity, but there again is a limitation both in terms of space and staffing in order to provide more services. So it's a positive thing for health centers, but it's also a challenge because of the workforce limitations.
Thank you. Any other questions or discussions?
Can I ask an information question? I don't recall. What is the plan for having the final projects written up so that they can be shared back at the home schools? Or what part of the expectation this time around?
We have to submit papers that have all the information in it. Like I need assessment like a 16, 17-page paper with information and data in it.
This is Melissa. I was actually back here asking Dominique if she might want to answer that question. I'm not sure if she heard it, though. In any case, I will say we do have all of the papers that the scholars have turned in for their projects, and I'm not sure 100% what the plan is for the papers. At this point, we may be able to have a special section on our newly redesigned website that will actually be launched any day now. FYI, everyone. And so there may be a place to store them there, but I'm not sure about sharing with the sites themselves. Perhaps someone else with more knowledge about that on this call might be able to mute themselves and chime in. But if that's an interest, Dr. Cunningham, I'll follow up with you about that after the webinar.
Well, one is to provide the which I think is equally important is where it means to take advantage of going to schools and sharing with your classmates and the faculty in the school, so that it helps spread the word about these types of experiences, and hopefully there's an opportunity to share that with potential students for the next cycle. It's like building a recruitment tool as well as an educational tool for the faculty.
Right. And also I know that I have heard from other faculty advisors projects that some of them, if not all of them, are potentially publishable. And, that's always obviously something that I'm sure everyone here would agree is a good goal to pursue for those students, those scholars here who are interested in doing so.
And I'd like to add, as a faculty advisor, this is Lois Wagner, I really enjoyed working with my scholar, and in retrospect, I felt a little disconnected from the actual site, and most of my communication was directly with the scholar, and believe that I would enjoy in the future, if I do this again, perhaps having an opportunity to connect more with the site and the students project the site. Also, again, as a faculty advisor, I think the idea of publishing is a very interesting and important one, and certainly would be happy to be involved in that as well with future scholars.
Terrific, Dr. Wagner, for those comments. And by the way, for everyone on this call, we have been in the process of evaluating our first program, and so we, of course, welcome all feedback and have been actively participating with our faculty advisors as a part of that process. So we definitely encourage that information. So,
you try to schedule them.
Thank you very much.
Any other discussion or any other? Are there any questions that anybody wants to throw out there before we end this third colloquium? Okay. Well, again, I will take this chance to thank Dr. Wagner for putting together this beautiful PowerPoint slideshow and presenting all of this great information. Really very much appreciate your hard work on this and enthusiasm for PCLP and our scholars. So again, thank you for doing this, and thank you to everyone who was here today with us. And feel free to send us emails or any other communication about the program. We welcome that, and I hope everyone has a terrific rest of your day.
Will you just say a word about Friday, if there's another one coming up for people on the call to read?
Everyone here should have received emails from me over the last few weeks about our webinar series. You will all be receiving an invitation from WebEx, what I call the robo-invitations, for the final colloquium, which will be hosted by Dr. Robert Philpott on Friday. And I believe his topic is community needs and community outreach. So again, Friday, 10 a.m. Central Time, but you will receive robo invitations by email from WebEx. So, and if you don't, please email me and let me know. Okay?
Thank you. It's been my pleasure, and I look forward to doing this again.
Thank you. We look forward to having you with us, Dr. Wagner, and again, Dr. Cunningham. We do appreciate your active participation today, as always. And everyone, have a wonderful afternoon.
All right. Goodbye.
Thank you. Bye-bye.